women's healthcare provider here in the Washington, D.C. metro area with the University of Maryland Capital Region Health. And so we see a wide variety of patients from all over the DMV region. The majority of our patients are Black and Hispanic and underserved or underinsured or uninsured with poor social economic status.
All right, so the topic today that I want to get into is what's behind the disparities in Black women's health. And so as a doctor who serves mostly Black and Hispanic women in a underserved population, what's happening with healthcare? What do the statistics look like, in the kinds of patients you see and in Black women in general?
Well, we're seeing budget cuts, we're seeing hospital closures and clinic closures, particularly in areas that are needed, urban areas. So for example, here in Washington, D.C., we have Ward 7 and Wards 8, which are both majority Black, with hundreds of thousands of people. And this is really all a systemic racism problem, right? These two wards have the highest rates of poverty. They have the highest rates of drug use, crime, and lack of access to healthcare. And so recently, this part of DC, which is east of the river, away from the kind of more affluent part of DC, there were several hospital closures and several clinic closures. And so for this region, which is a vast, big population, there are no hospitals that provide obstetric care or women's health care. So these young women have to go either out of state to Prince George's County, so they'll get reproductive health care or obstetric care, or they have to go to other parts of the city, way out of their way to get the care that they need. And so this kind of just trickles down. It's a big cycle. You're closing and not giving these people access to healthcare, and then they have to go out of their way to get transportation, childcare, just to be able to get the proper healthcare they need. And here you have this whole region of one city that has no hospitals for these people to go to. But this really is systemic in nature. I mean, this goes back to redlining, housing discrimination, that these people are packed into one region. And here we are in 2022, where they have nowhere to go. And oftentimes with women's healthcare, and particularly with obstetrics, time is of the essence. So if you have a young lady who's showing up to somewhere in labor with nowhere to go, she's having an obstetrical emergency, she's bleeding, she got hit by a car, and then you have to put her in an ambulance and transport her 20 minutes away or 30 minutes away to a hospital that probably doesn't even want her there, majority white hospital, or where there are clinicians who don't look like her, or who don't understand her social status, or are able to communicate with her, then right there, that's a high risk of infant mortality for that baby and maternal mortality for that baby. So this is just systemic in nature.
So, it's interesting to me that, everyone, what I always grew up knowing DC is Chocolate City, right? So the idea that there's a whole region of DC with no hospitals, such that you'd have to go to Maryland, PG counties in Maryland, that part shocks me. But I just wonder if, do food deserts parallel with healthcare deserts? Like, is it all, because you mentioned redlining and systemic. So is this all a part of the same cycle? Like, you don't have food, you don't have quality housing, and you also don't have healthcare. Are they all kind of wedded together?
Yeah, definitely. You don't have food, you have a lack of access to educational resources. So you have a higher high school dropout rate. These ladies are more likely to fall out of the system, right? Not able to get jobs, or more likely to get on social welfare programs. And they can't go anywhere to buy good groceries. That contributes to obesity, high blood pressure. This, not only in their pregnancy care, will put them at high risk for all kinds of complications. Then you have nowhere for them to go to even get care. Here in Ward 7 and Ward 8. I mean, in a whole big city, the nation's capital, right, where this is happening. And so this trickles down and it causes a domino effect, basically, where this goes all the way into your healthcare and your own personal health, where you're not getting proper care that you need or access to care, or you're falling out of the system. And all you have to do is you got to worry about how am I going to get food for my kids? How am I going to go to work? The last thing on your mind is your healthcare, especially when you don't have any quick, easy access to it. So it's a big domino effect. It's a big spiral effect. Systemic racism, still we are here in 2022, dealing with the same issue.
So what I think is interesting when we talk about the numbers for Black women's healthcare, especially infant mortality, and maternal mortality rate, economics don't matter, right? You know, a woman like me has a higher infant mortality rate or maternal mortality rate than my peer of the same education and income background. And so the numbers don't change when we have more resources. Is there a reason for that? Or do y'all have a clinical reason why you believe that is?
Well, clinically, there's still a lot of underrepresentation in medical schools, pre-medical programs. You don't have physicians, Black physicians who look like us, or physicians who are competent in cultural care. So you still have, to this day, white medical students who literally think that we have thicker skin. Black people, they're still being taught this in medical schools. And so they think we have a different perception of pain. You have Black women who are unlikely to have their symptoms of pain and other issues quickly assessed by a nurse, by a physician. Let's take Serena Williams, for example, right? Arguably the world's greatest athlete, the world's richest athlete, who had to advocate for her own self during her postpartum care. This is a young woman who had a pulmonary embolism, as you know, blood clots. She had a high-risk pregnancy. And then she gives birth in this nice, fancy white hospital. And she goes on her first day after having a C-section. Mind you, this really high-risk young lady. And she's complaining of chest pain. And she goes and tells her nurse, and they ignore her symptoms and dismiss her. And Serena, who has a voice, who has money, is able to advocate for herself, has to go to these people and tell them, you know, I've had pulmonary embolism in the past. I'm a high-risk patient. You all need to get a CT of my chest right now. The nurses still dismissed her complaints. You know, Serena talked about this a couple of years ago after she gave birth. And she ended up with what? Another pulmonary embolism that could have been fatal and killed her. She would have been another statistic of maternal mortality. So that being said, no matter your socioeconomic status, you're still going to face systemic racism. Your complaints are more likely to be dismissed. And this is Serena Williams we're talking about, who has a voice and is able to advocate for herself. So imagine all of the millions of young, poor Black and Latina women who are out there unable to advocate for themselves, dealing with the same issues. This is why our maternal mortality rate is a lot higher.
So how bad are the numbers? Like I keep saying the numbers are bad, the numbers are bad. How different is the healthcare outcomes for Black women, than our peers who are white or even our peers who are Latina? Like, how bad does it look?
And this is still regardless of socioeconomic status. The numbers have not changed in over 30 years. Still, because we're in this era of systemic racism that's still existing. So reproductive health, Black women are still more likely to be diagnosed later with breast cancer or cervical cancer. They're still more likely to die from a heart attack or lung cancer, which are the four most common killers of women nationwide. They're more likely to not get access to healthcare, more likely to not have diagnostic tests run, or have their complaints listened to by white physicians who just aren't culturally in tune. And this is regardless of socioeconomic status. And the maternal mortality rates are still high. I mean, a Black baby is more likely to not come out of the hospital alive after it's been born, still here to this very day in 2022. This is regardless of socioeconomic status. So this is a systemic issue that's still been in place for a long time that we still haven't been able to resolve, because we still have this lack of representation in healthcare, particularly at the higher level with physicians, physician assistants, nurse practitioners, and nurses. So if you don't have people who are looking like you take care of you, then you're more likely to have poor outcomes.
So I'd love for you to, tell everyone, you're a doctor working with an underserved population. Obviously you could be like a plastic surgeon and be a millionaire, or like, doing something there are things that doctors do that pay a lot more money and that work a lot less hours than what you do. So what inspires you to serve the population you serve? And, what made you want to go to med school, and what made you want to, do what it is that you do every day?
Well, growing up, I didn't see people looking like me, taking care of me, particularly the women in my community. And coming from Baltimore, and then coming from an area where I saw a lot of teenage pregnancy, not only in my own family, but I saw it in high school. And I saw young Black women just not getting the proper access to healthcare. And so somebody who looks like me doesn't look like me. How are they able to take care of me and know my needs? And so that's kind of what inspired me, just to be able to come back into my own community, and give back. Because you see, there's a trustworthiness. Black people still don't trust going to the doctor. This dates back to slavery, when we were experimented on. But just even seeing my face when I walk into a room, it just brightens up so many people's days. They feel so much more at ease because they know that this person's probably going to advocate for me. They understand me. We come from the same place. We speak the same language. We speak the same lingo. So for me, it was about increasing representation, particularly of people who look like me, Black men, in medicine, be able to take care of my own community. Because you see these same things are still happening. There are people dying, particularly for women, because I saw that with the women in my own family, not getting the proper access to healthcare that they needed. My own mother would go for God knows how long without getting treated or being seen because she didn't trust doctors. There were no doctors that looked like her. So,
Wow. And why obstetrics and gynecology?
well, who's the most undervalued group in America? Black women. Okay. And I think it's up to us as Black men to protect them. I've always had an interest in women's health and birthing babies. This probably dates back to being a Cosby kid and seeing that on TV. But hey, that was an influence too. I saw a Black doctor on TV. It's like, oh, I want to be just like him. But particularly for me, in seeing all the generational cycle of poverty and teenage pregnancy in my family, that was something I wanted to do to prevent that. So that's why I got interested in women's health. And it's a field where you can be a specialist, but you can also be a primary care provider, because oftentimes I'm the only doctor a lot of these young women will see, in their whole entire lifetime. They either only go to the doctor when they get pregnant or when they come for their annual exams. And so I'm often at the front line of diagnosing things like hypertension or diabetes, because pregnancy manifests these things, right? So a young 25-year-old lady may come and see me just for her annual exam, won't see another doctor, and I notice, oh, hey, Ms. Jones, you got high blood pressure reading. Are you seeing your primary care physician? So oftentimes I'm the first line agent, first line provider that they see. So it's a combination of being able to be a specialist, but also able to be a primary care physician at the same time.
I love that you say that you are the first line person and you do the PCP work anyway, because, I've gone to OBGYNs and I feel like I'm rushed in and out. So, the idea that there is a OB-GYN who's serving that double role is interesting to me, because that's not an experience that I have always had. Is that normal? Is that what you are taught to do clinically, or is that what you do because of who you are and what you know about your patients?
I think it's a little bit of both, because I went to medical school at Howard, so I was around Black folks all the time, and I was around these patient populations all the time. So we were taught differently. We were taught more cultural competency, versus going to a white medical school where they don't see this kind of patient population. And I understand that in the region where I work, a big urban area like this, where I'm seeing a lot of poor and underserved patients, that's just a socioeconomic status. That's your clinical training. That's your knowledge. That's your upbringing. That's the connection that I have being a Black physician. I'm able to see, okay, I know that this young lady's likely not gonna come to the doctor again unless she gets pregnant. So I need to address these issues with her now so I can stop anything from happening in the future. So, the majority of women only see us during their reproductive years for the healthcare. And so it always told me to be more a very astute physician, maybe to see these kinds of things, whereas other positions, they just want to get you in and out, just want to be a specialist.
Wow.
Mhm.
Wow. So, you know, we talked about housing, right? And we talked about being in food deserts. You know, I've read about things like using relaxers causing fibroids, and living in a poor area with mouse dander having a more propensity for asthma.
Mhm.
Are there, like, one, are those things true, or is that just like urban legend? And is that why, you know, Black women have more fibroids, or Black women have more of these things, the environmental things? Or is, you know, are there other reasons perhaps behind why, you know, Black women have more of a tendency towards things?
Well, so let's think about it again. This is a domino effect, right? So here you are, we're starting with redlining. You're put in the districts where you have lack of access to food. So what are you gonna go do? Eat fast food, right? Where does that go? You're contributing to obesity. What does that lead to? Heart disease, diabetes, hypertension. Where does that lead to reproductive wise? You get women who are overly obese. They have problems with their menstrual cycles, like PCOS. Um, and then being overweight can put you at risk of fibroids. So it's just a big clinical domino effect. You're in poor housing with rat dander everywhere. That's going to increase your chances of having asthma and pulmonary disease and lung disease. You're in a place where you're getting exposed to drugs and crime. So you're more likely to turn to drug use, and that's going to increase. Again, it's a big domino effect. How you see it starts in the home, it starts in the neighborhood, and it starts, you know, in the district where they live. But this food desert, poor housing, unaffordable housing, it's all a big cascade that contributes to your overall healthcare issues, particularly for women.
And what about things like chemicals, right? You know, we all read, or at least I do, right? When it's like, oh, because everyone of your generation relaxed their hair so young, that's
Mhm.
why more women have, that's why Black women have these cancers, because you're exposed to chemicals in that way. Or because, you know, your house is carpeted and you're inhaling fumes, you know, which to me sounds like people are putting the blame on us, right? Like what you did to your hair, how you chose to decorate your home is why. And my question is, like, are those factors, or is everything else you talked about a much bigger deal?
I think everything else is a much bigger deal. But again, chemical relaxers, you don't know what's in that stuff. I mean, there are no real studies about it, but we've seen an association between chemical hair relaxers and fibroid. But we've also seen that with diet. So it's really a big cascade effect, but it's more attributed to that systemic racism that's caused you to, why do you want to go relax your hair all the
That
time?
too.
You know, so
Yeah,
it's still an effect, even mentally.
right. No, that's a very good point. Like, nobody wants to relax their hair unless they are told that their hair in its natural state is not attractive or professional or all those other things. So you've talked a little bit already about how your identity makes a difference, and you've kind of alluded to going to Howard Med School and the things you do clinically. What, you know, what are some other ways that your identity as a Black man, do you think makes you a better physician? And I guess my other question is some of what you do teachable to people who aren't people of color?
Yes, because I think it all boils down to trust, and being able to culturally communicate. And I'll give you an example of this. I had a white medical student who was following me around. I said, go in and take this patient's history. So he comes out. This is a young lady who's at the beginning of her pregnancy. And the important things we asked: medical history, family history, but particularly social history. Do you smoke? Do you drink? Do you do any drugs? And so he was like, yeah, she denies knowing any of that. She doesn't smoke, she doesn't drink. I said, okay, come on. Let's go see. So I said, hi, young lady. So you smoke gas? She's like, oh yeah, child, I do Kush, OG, all this other stuff. And yeah, and I use the funnel and I roll it in the cigarillo sometimes. And the student was just sitting there like, oh wow, she told me she didn't smoke anything. So I told him, when Black people say smoke, it means something different. She thought she meant smoking cigarettes. No, this lady is smoking marijuana. And here you just potentially missed a big, big important thing about marijuana use and tobacco use in pregnancy that it could complicate her pregnancy because you didn't know how to ask the right questions. And then me and this lady had a 5-minute conversation about all the types of marijuana she smokes and the paper she uses. And I had to warn her about, well, you don't want to use funnel, you don't want to use leaves, you don't want to use game, you don't want to use cigarillos because that tobacco use can cause you these types of issues in pregnancy. And the student just sat there like, oh, wow, I just completely missed it. And I was like, yeah, that's the point.
Wow.
You have to know your population, you have to know be able to communicate. You have to be culturally competent because otherwise you're going to miss things like this. That lady wasn't comfortable telling you that, but she didn't know how to ask the right questions. You didn't need the cultural competency. So I went in there and I, defined smoking as we as Black people think it, at least over here in Hampton County in Washington, D.C. And it just completely opened up a door that the student was like, oh my God. So I think it's just little nuances like that where cultural competency and cultural sensitivity and cultural training. I mean, also even things just like, different cultures express pain in different ways, right? Women who are of Southeast Asian descent may be very, very stoic and more poised. And so she's telling you she has pain, but you see it, and you're looking at her face, she's not saying anything, then you're going to dismiss her complaints. African Americans express pain differently. White people express pain differently. It's just those little things and those little nuances that could keep things from being missed and near misses. But that little weed lesson with my white medical student just completely opened his eyes.
Wow. Yeah, it's something where when you said that, I was like, if someone asks me if I smoke, I assume they mean tobacco. If I'm in a doctor's office, right? Mm-hmm. Like if I'm in a doctor's office and you say smoke, I assume you mean tobacco. And the form actually probably just says tobacco. And then it says like drug use. And so many people don't think marijuana is a drug, right? Because it's like, well, I'm not shooting up heroin. I don't use drugs. And I don't smoke cigarettes, so I don't smoke. And just you saying that had me like, oh, wait, I would answer those questions exactly the same way if I were that woman. And a white doctor asked me, right? Like, I would.
But if we were out in the street and you say you smoke, you think it's a different thing, right? But this white man doesn't notice because he hasn't been exposed to this. So fortunately, he was here with me where I could teach him that. But what if there was another white physician here and they didn't delve into that topic? We would have missed a whole complete thing that could have completely changed the course of her pregnancy. So cultural competency is very, very, very important. It's still lacking here. I mean, still white medical students, like I said, they think we have thick skin, different pain receptors when we don't. And this is being taught here in 2022.
So, you mentioned near misses, and your role as an interventionist, right? So, as the doctor who intervenes, especially in a community like PG County, where you're servicing the people who are coming from the 7th and 8th Ward who have to cross over into Maryland, how has your presence impacted outcomes, you would say? What does your presence do for your patients?
Well, you have early intervention and late intervention, but I can say my presence gives a sense of trust. So patients are more likely to open up to you and actually tell you what's going on. My presence has stopped a lot of near misses, near catastrophes, because there are things that I, as a Black physician, am clinically astute to catch. That someone else may not see, just little nuances, little things like that. Like I could see, for example, patient came in and was overdosing on PCP. The white physician is looking at her like thinking she's cutting up and just having a mental breakdown. And then I'm looking and I'm like, no, I seen this on the street. She's had this certain drug. And here and behold, this is affecting her baby while she's in labor. Mm. And so had that been missed, this lady would have come in with a dead baby. Just kind of little nuances like that. Our presence makes a difference because we're able to catch things and we're able to communicate with our patients in a cultural sense that brings a sense of trust. Patients are more likely to keep their appointments. They're more likely to take their medication. They're more likely to follow your instructions because they trust you as a Black physician. I had a patient tell me that the other day. She's like, I only see Black doctors because I don't trust white doctors. Unfortunately, for the experiences that she's had in the past, she felt like they didn't listen to her. She felt like that she was being experimented on. So, the onus is on me to have a presence where I'm able to save lives just by the color of my skin and me being able to communicate with these patients culturally. It's prevented a lot of deaths or near deaths.
Wow.
Mhm.
Wow. I'd like to talk a little bit about gender identity and sexual orientation, especially in the Black community, and how that impacts the patients you see. I feel like we say Black women, but I should probably say Black non-men. And I would love you to talk a little bit about your treatment of the queer community and what that has been like, especially in a community like PG County that is Black, and we have our kind of cultural stigmas about that kind of overarches it.
Mhm. Well, I can first say that I'm kind of a unicorn out here, an openly Black queer male physician who takes care of women, right? So I have my own cross or intersectional identity, right? Because I've had to deal with racism from white physicians and homophobia from white physicians. I've also had to deal with it from other Black physicians. And so us Black queer physicians, we're kind of a subculture within a subculture because we're such a rare unicorn or unicorns. You understand what I'm saying? And for young Black women of the LGBTQ spectrum, I'm just going to say queer, whether you're transgendered, they're already starting out behind. So they're more likely to be homeless because their parents put them out of their home. They're more likely to resort to drug use because they're facing discrimination because of their orientation. Imagine being a Black queer woman. Here you have to deal with class, right? Racism, homophobia, and misogyny. And the last thing on your mind is your reproductive health, right? So they're already starting behind with lack of access to healthcare, particularly for transgender women. And so they fear going to physicians, period, because they're going to have to deal with all of those issues at once. They deal with it from Black physicians. The homophobia they deal with from Black physicians is horrible and strong. And so they feel comfortable with me because I can understand that cross-sectional identity, particularly when it comes to things like reproductive health. They may not understand that, yeah, you may not sleep with men, but you still need to get a pap smear. I had a young lesbian patient come in her 50s, never got a pap smear before with cervical cancer because she didn't know. Like, no, doesn't matter if you sleep with men or not. You still have to get a pap smear. A lot of transgender women may not know if you have breast tissue, you still need to get a mammogram. So the other issue comes with people who want to plan families. So they're going to already have going into a business, a fertility business, which is mostly cash only. And so these patients are unlikely to have insurance. So they go to extreme measures to start a family. I've seen women order a basic kit from Amazon and then find a random donor out in the neighborhood and inseminate themselves because they can't get access to that proper reproductive technology in the office. Why? They can't afford it. Two, they're going to face homophobia from physicians. They're going to face racism and discrimination from physicians. And me being this, I guess, intersectional physician, is that what I'm going to call myself? Am I intersectional physician?
I think you're intersectional. You're intersection. You're definitely a unicorn. You are most certainly a unicorn.
So they feel comfortable with me. Oh, here's a Black queer face that I can come and talk to about my reproductive health. Just even simple things about sexual practices, using sexual toys. Oh, I can still get this and this. How am I supposed to properly clean it? Just things that they feel comfortable with that they wouldn't otherwise go, because, that they're Black women, but the Black queer women are even lower in the totem pole and even at higher risk for these things. So I think it's very, very, very important not only to get young Black medical students into primary care fields, but young Black queer students, because it really, really, really makes a difference, particularly here in DMV or Atlanta, where you have a huge, huge Black queer population. It makes a difference.
So I know that folks tune in for advice. So I'm going to kind of start with where we just ended with queer folks and kind of work backwards of, obviously not direct medical advice. I wouldn't do that to you because I am a lawyer, but just kind of the preventative care suggestions that you would give. And I'll start with trans women. So first of all, if someone is transitioning, either male to female or female to male, which specialists should they be seeing? Like, should a woman who's transitioning to male always come see you? So I'll start with that.
So let me start. First of all, you should not be getting your hormones off the street. That's the big thing. Again, like I was saying with our poor queer Black and Latinx people who are ashamed for what they're going through. Often their health insurance doesn't even cover, if they have health insurance. Medicaid particularly doesn't cover hormonal treatment and transitioning treatment. So that would be my first thing. Do it safely. Do not go get injections from Cinnamon up in Baltimore. Do not go and do that. Would be my first suggestion, is to do everything safely and that there is access out there for you. The thing I say first of all is, regardless of who you're transitioning to, is that you have to understand your reproductive proper health screening, right? So if you still have your anatomical female parts, whether you identify as male or female, you have to get a pap smear, regardless, right? If you have breast tissue, whether you consider yourself cisgender, wherever on the spectrum you fall, you need to get breast exams. Okay. For people who want to transition, who want to do it properly, the first step is to see an endocrinologist. Okay, so they wouldn't come and see me because that's not a part of our specialty. We can do their preventative care and their screening. We can take care of them when they're pregnant, but they would first see an endocrinologist to begin the hormonal process. And then the next step, if you're considering surgery, then you would see it's actually called an andrologist, which is a branch of urology. It's a urology subspecialty who takes care of those patients. But I just implore you to do it safely. You're not going to do it off the streets, because I've seen too many potential complications come from hormones and injections. I mean, you've seen them botched, right? Getting hormones off the street when you don't know where you're getting it from, and it can cause you to have a heart attack or a stroke. And so that there is access out there. Okay. Washington, D.C. takes care of its residents pretty well. So does the state of Maryland. And so most insurances are now covering treatment to transition from one gender to another, particularly Medicaid. So that I would implore people to do.
Right. So we got, get the proper treatment. As long as you have the anatomical tissue, that is the doctor you need to see. So that's our two takeaways there.
Right.
Don't let Cinnamon inject you in the house in Baltimore. Don't let Cinnamon do the butt shots either. Like, don't let Cinnamon do that. All right. So let's next do, you're a cisgendered lesbian. You talked about pap smears. If cisgendered lesbian doesn't want to have kids, what's the preventative medicine that she needs to come to you for?
So, cisgender lesbian women, or bisexual, however you identify, whether or not you have had sex with a man in the past or never had sex with a man in the past, your cervical cancer screening is important. Please go get your pap smears, because you are still at risk for cervical cancer. Please go get your annual breast screenings. And when you get over the right age, mammogram screenings. Okay. And even primary care wise, please take care of your blood pressure screening, your diabetes screening, your thyroid screening. Okay. If you're not having sex and you're not contemplating pregnancy, then no, you don't need birth control. But we still prescribe birth control for a variety of reasons. Okay. And also, safe sexual practices, using dental dams. If you're using sexual toys like a strap, I had to tell a young lady how to properly clean her strap because she was wondering why her partner kept getting infections all the time. She was using improper treatment, just throwing it in the water, or use the same toy with another patient because you can still transmit infections that way. And a non-intersectional physician wouldn't be astute to this kind of knowledge. So when they come to me and ask me these questions, I'm telling them this for the first time, they're completely floored. Like, oh wow, I didn't know that.
Well, and I could understand why, because you're like, well, it's not attached to a human being, so why does it matter, right? But bodily fluids are bodily fluids, right? So they transmit and transfer. All right, so I think I think cisgendered women know what to do for reproductive health, right? We know if you get pregnant, you need to go see the OB-GYN, whether you go or not. Cisgendered women know about breast exams for the most part. What about other preventative? Well, actually, I want to ask about fibroids. Is there anything that we can do to prevent fibroids, to make them better? Because, especially at our age, so many of our friends have had to have the fibroid surgery or are currently suffering from fibroids. So, is there something that the 20-year-old could be doing so that they don't get to be 40 and have the issues that my friends have had?
Let me go back to your reproductive health question with the cisgender lesbian patients. If you desire to plan a family and start a family, come and talk with your healthcare provider first, because there is access out there for you. So you may fear being discriminated against, and you may fear that it may be unaffordable or unavailable to you. But do not go doing extreme things like buying a insemination kit off of Amazon and then asking your random trade friend off the street to donate sperm. That's not safe. Okay. So come and see us. We can get you the right resources that you need. Fibroids, on the other hand, are a very, very complicated thing because there's lots of factors. A lot of it's genetic. Okay. Some of it's environmental. So is there anything you can do to prevent fibroids? Not really, but some things that can contribute to it. Diet, obesity. When you got extra fat, right? It's going to make you mess up your menstrual cycle. That's going to put extra estrogen in your body, which can make things grow in your uterus or in your ovaries. So diet and nutrition are a really, really big important thing. Family history. If you know anyone in the family who's had to have a hysterectomy at the age of 30 because they bled so much, then that could likely happen to you. And this goes for all women who still have their anatomical female parts. Okay. Ovarian cancer screening. There's really no screening for ovarian cancer, but we know that pregnancy, or we know that birth control is actually protective against ovarian cancer, right? Because you're not ovulating, so you're not causing any damage to that outer epithelial lining of your ovary. So contraception can actually be protective against that. But fibroids in and of themselves is no real way to prevent them or treat them, but I would say don't ignore your symptoms. Okay, so don't go for years and years and years having these heavy menstrual cycles, and all of a sudden you show up in the emergency room with a low hematocrit and you have to get transfused. Pay attention to your symptoms early, because if you catch them early, you can get the proper treatment for them early, and you can prevent them from becoming a bigger issue in the future.
So what are some symptoms? I feel like I'm just asking you all the questions people ask me because my best friend is an OBGYN. So what are some symptoms that, you as an intersectional, interventionalist, that's what I call you now. What are some symptoms that women should complain more about when they go to the OBGYN, or that other doctors ignore, that could have consequences. So you talked about heavy cycles and that being one. Are there and other symptoms that especially are prominent in Black women that maybe, that's a bigger deal and I shouldn't ignore it if a doctor's dismissing me?
So the biggest symptoms that are often, well, what are the main reasons women come to the gynecologist? Bleeding issues, pain. That's a big symptom that women often ignore. Pain. If you're having pain, you need to have it evaluated because your regular primary care physician may dismiss it as, oh, she's on her cycle, she's having menstrual cramps. Pain, abnormal discharge or odor, and then not just heavy bleeding itself, but your cycle is off, your cycle stops. You stop having a cycle for months. That could be an issue. So those are things you don't want to ignore because you could be missing all kinds of things, not just fibroids, but hey, you're having pain, you could be missing huge cysts on your ovaries that may require surgical intervention that could compromise your fertility. Also, screening, STD screening. Yes, we recommend that, particularly in our population, screening for gonorrhea, chlamydia, HIV, because the rates are still high, okay, in our population. Those are things you do not want to ignore. Even if it seems slight or minimal, there could be a very, very big underlying issue there that could potentially cause you a lot of problems in the future.
Now, we know Black women are always booked and busy, right? We're always booked and busy. Who has time to go, we'll make time to go to the gynecologist because that's how you get your birth control and you don't have a choice. But we're often not making our doctor's appointments to go to see the other doctors. We're not doing the things. So, and we have higher rates of diabetes and heart disease. And we talked about strokes and Serena Williams's pulmonary embolism. What are the things we should be doing and screening for to prevent those, negative outcomes as well? And then how do we advocate for ourselves if a doctor is ignoring us with those things?
Yeah, that was going to be a big thing I say. Advocate for yourself. You have a voice. Talk to, one, I would say, don't be afraid to get a second opinion. Okay. And two, when you go to the doctor, don't be afraid to spill the beans, spill the tea, open up completely, because we need to know these things. There are things you're not telling me that I don't know in your chart, then we could miss something. So do not be afraid when you go to the doctor, when you go to the emergency room, to open up. Your medical record is confidential between you and that physician. Advocating for yourself. Well, first I would say, try to seek physicians that look like you, that you feel comfortable with, because oftentimes it's a vibe once you walk into the door. And if you feel like that all your needs are not addressed, then it's time to go somewhere else. Okay. But I would say first and foremost, try to see a physician that looks like you, that understands you, excuse me, that understands you, that understands where you're coming from, that understands where you've been. Okay.
All right. So, we've kind of been negative the whole time when we talk about these outcomes and intervention. Our friend Cameron Matthews does have this program that tries to help more doctors or more Black people become doctors. There are other people who are working to change, because the problem I've had is, I often know that, I at least need I usually look for female doctors if I can't find a Black doctor, but Black doctors are very hard to find. And y'all are so booked up, not taking new patients, all of that. And so it's so hard to find, a new Black doctor, especially. And things are hopefully changing in that regard. But is anything changing? Like, are things getting better? It seems like we talk about these statistics now, I can see it on MSNBC or CNN. And I can read about it in the Washington Post or the New York Times or, in every newspaper. Now that we all know that Black women health disparities aren't changing and look the same way they did 50 years ago, has there been a change to medicine or public health since we now have this awareness?
Well, I can say the thing that's helped in recent years has been the Affordable Care Act. it didn't give a single payer where everybody could get access, but it at least opened the door to Medicaid expansion to get more people under the umbrella of healthcare. It also provided funding for clinics that help the underserved, which we call federally qualified healthcare centers, which is where I've worked for all this time, where we see patients who are uninsured or underinsured. So there has been improvement. We've seen a decline in the number of Black applicants to medical schools. That's for a lot of reasons. One, there's just a lack of interest. It's a long process. It's costly. However, fortunately, we've seen an uptick with COVID in the number of young African Americans who are interested in going into medicine. So we don't know how long that uptick will last. Hopefully, it will last a long time. The other thing is that we talk about Black inner city and urban America, which is where a lot of Black physicians will congregate in these big metropolitan areas, right? But we forget about Black rural America, mm-hmm. Alabama, Mississippi, these places where there aren't doctors for hundreds of miles, and they still have the same healthcare disparities that inner city or urban Black women and Black people do. So particularly the good thing about Cammie's program is that she's also recruiting people to go out to those regions to practice, because we need to see more people like that. But we can't forget our fellow Black brothers and sisters out in rural America. So.
You know, that it's because I live in Charlottesville, and so, which is quasi rural. So, you know, like finding a Black doctor here is virtually impossible. You know, what's interesting, I wonder, so do Black nurses and PAs make a difference with intervention?
Yes, they made a huge difference. Particularly, they're the frontline primary care agents, nurse practitioners, physician assistants, nurse midwives, because we've got this uptick of medical students going into medical school, but when they get there, they don't want to go into pediatrics, they don't want to go into family medicine, they don't want to go into obstetrics and gynecology, they don't want to go into these fields where you have to work hard and not make all this money. They want to be orthopedic surgeons or dermatologists or radiologists. And so we still are having a lag in physicians going into primary care, particularly Black physicians. So where the gap is being filled in, which is wonderful, are the nurse practitioners and the PAs, particularly for our specialty, because they can take care of the uncomplicated things, like your routine healthcare screening, your routine pap smears and mammogram screening, your routine diabetes screening. They can leave the complicated patients for the physicians to see. So it's freed our schedule a lot. And also these nurse practitioners and PAs and such are going out into these rural areas and taking care of these patients where physicians don't want to go. So they made a huge difference. And we thank them.
Yeah, I asked that because, you know, people say med school takes too long, or I don't want to be a doctor, I don't want to do all that work. And I just want to flag that as a career possibility for people, right? Like, you could still be in healthcare, you could still service patients, not spend as much time that doctors spend in med school, and make an impact and help address these disparities, right? You can be a piece of the change, and help to, you know, just make everything better. Because it's always crazy to me. Like it's always crazy to me that, you know, my chance of surviving breast cancer is higher in like Cuba than in Washington, DC. Like that is literally the truth. Like,
and I always tell them, you aren't any less of a practitioner being a nurse practitioner, because it's a different model of care. Nursing is a different model of care. Being a physician, that's a different model of care. If these people wanted to go to medical school and be doctors, they would be, but they provide a different model of care that is effective and works well for patients. And so they're greatly needed. And so that's where a lot of these clinics are turning to. We call them mid-level providers, but providers who aren't MDs for that specific reason, just because Black doctors, particularly who are finishing medical school, just aren't interested in going into primary care. It's fortunately we've seen this uptick with COVID in the application process, but we don't know how this is going to maintain itself. Okay, well, only 2% of physicians are women, Black women, and even less than that are Black men. So there's still a long way to go.
Well, that's a good way to close us out. So my last question for you, if you could wave a magic wand and resolve some of these problems, what would you do? If you were truly a unicorn with a magic wand, what would you do?
Well, if I were truly a unicorn, I would have had the Affordable Care Act do what it was supposed to do, provide single payer health care for everybody to get coverage. That would be my thing. If everybody had insurance like Canada or Great Britain or some of these other countries, we probably would resolve a lot of healthcare disparities.
Single payer. I like it. That feels simple to me. That feels like an easy one. Like all we need to do.
Yeah, so that's not going to really work here, but I think that would resolve a lot of our problems.
I think it's sad that it's so simple, but it could work, right? That's what's the saddest thing to me, that all it takes is getting everyone access to healthcare and an affordable healthcare system to save lives. And we've seen it with COVID, right? We've seen it with people getting vaccinated and seeing it with people, getting COVID treatment, that all it takes is money and access to make a difference.
It does.
Well, I would like to thank my dear friend, Richard Jones, the Dr. Richard Jones, who has been my friend. I won't say the year because I won't acknowledge that we are that old, but who has been my friend forever. And so it was nice to get to have a serious conversation with my BFF for a change about women's healthcare and the disparities, and to celebrate him as an interventionist and for what he does as a, triple intersectional doctor, right? That he is, and as a unicorn. So thank you all for listening to Get in Common. If you ever miss an episode, you can catch rebroadcasts anywhere podcasts are played, and on the Voice America Network, and also on our YouTube channel. Feel free to send me emails through the show page or to reach out to me on social media. I am at Carla C on all platforms. Thank you again, Richard, and thank you for listening.
Okay. Bye.
Bye.
I would say leave.
All right.